She is the founder and director of Balex Balance Rehab. She specializes in vertigo, balance, and vestibular rehabilitation and tinnitus management. Her professional qualifications include training in vestibular assessment and management, as well as balance rehabilitation. And she also serves as a director of a vertigo support group in Malaysia. She also won and bagged 40 gold medals in regional and international invention competition and had published more than 65 books and has authored 60 journal articles. Let's welcome Dr. Zoraida Zainun as she shares the latest updates on vestibular rehabilitation with prayer movement. A round of applause.
Bismillahirrahmanirrahim. Allahumma salli ala Sayyidina Muhammad, Allahumma salli ala Sayyidina Muhammad. So thank you so much to all, and especially to the organizer. So I am Dr. Zoraida Zainun, which is from Malaysia. So I've been in dizzy clinic and vertigo clinic for 16 years. So I really hope you are not dizzy with my lecture, inshallah. Alright, so basically, I think management of balance disorder and vertigo is very complicated and unresolved and discussed all over the world without end point. And the most important thing, there's a lot of conflicts and research that we involve in terms of like diagnosis and also the treatment. And I don't know, if you look at in Malaysia also, they are only dependent on the medication, not exercise. And compared to Europe and UK, they are more prone to the exercise, which is balance exercise can improve the balance without medication. And when you are talking about the selections of the treatment, the central and peripheral vestibular disorder is undoubtedly is a very important. If not, you're going to have a wrong diagnosis and wrong management, and you're going to have long-lasting vertigo patient in your clinic. All right, then there is a lot of research shows that physical exercise has been shown to improve patients with peripheral and also central vestibular disorder. Okay, if you can see here, this is like one of the survey, epidemiology survey among 70 million. And if you can see here, the follows our conference or our WIPU thema this year, the geriatric. You can see here there are a lot of like aging prevalent 74 to 94 years are commonly affected, dizziness, vertigo, imbalance, and even post-stroke people. So you can see here, from this graph, pre-syncope, rotting sensation, feeling like on board all the time, imbalance, and vertigo, 80% or what we call that majority are needs better exercise, apart from BPPV, which is what we call benign paroxysmal positional vertigo. I'm so sorry, this is quite complicated, but I think I love this chart because I can conclude here, if you can see, here, the majority, the orange color is actually acute vestibular syndrome. It includes benign paroxysmal positional vertigo, which is existence of the otoconia inside the posterior canal, 85%. The rest can be anterior canal and also lateral vestibular or lateral semicircular canal. And the rest, they can be lots of things. Okay, so when you're talking about dizziness and vertigo, this is what I'm only emphasize. The most important thing, this sulfide test is a must. This sulfide test is safe. You just need a clinical skill and you need to confirm whether this patient having BPPV, benign paroxysmal positional vertigo, or non-BPPV. The common symptom for BPPV is very common. When you are waking up from sleep, whatever deep sleep or low sleep, they're going to have like a positional vertigo for a few seconds. No hearing loss. And after that, they can go to shopping, they can go to play football. They are only related to positional related, which is when lying sleep and waking up from sleep. So this is typical BPPV. For non-BPPV, they are very different. They are not related to waking up from sleep and lying down. So that's the reason why I'm saying this sulfide test. a very simple task need to do in all vertigo patient, in all dizzy patient, in all imbalance patient. Alright? So, when you are talking about management, if a patient is BPPV, the best method is actually, it depends whether posterior canal 85%, the most common one. So you can do every maneuver, but in Europe, they do this more than 10 years. So the best method is actually Siemens maneuver that I can show the video after this, and gun CRM, which is done by Professor Richard Gunn from American Institute of Balance. It's quite simple like Apple, but they are shaking. So I will show the video.
People who can use
I'm
AI
very
tools
happy
are
to show
very
that.
smart.
I'm not going to make you more dizzy after my lecture. Alright, so this is the video. Alright, so this is my balance rehab clinic for 16 years. I'm with University of Science Malaysia under neuroscience. Alright, so this is what we need to do. This is the treatment for posterior canal. This is what we call Siemens maneuver. Okay, face out. You have to turn the head contra side. If the affected is on the left, turn to the right, face up, face down. And you see the nystagmus? Yeah, it's a posterior canal BPPV. It's a rotary upbeating. Alright? You can say anything. You can ask them to do like Ashhadu an la ilaha illallah or whatever, just to make them calm. Alright? You just wait. In vertigo patient, you have to do very polite, very slow. Don't need to be rushed. Alright? If not, you're going to be a zero patient in your vertigo clinic. Alright? Alright. And then we're waking up. That's all. This is very simple. This is the reason why I'm saying here, Siemens maneuver is applied in UK. Aptly is not being used for more than 10 years in Europe. Alright, welcome. Alright, next. So you can see here, when we conclude, the BPPV, benign paroxysmal maneuver, is actually maneuver. The rest, balance exercise. But if you don't forget, you don't know about the balance exercise, you just remember prayer. Salat. Okay, so our life is more simple. If you are dizzy, if you are not BPPV, pray. Don't leave the prayer, do the exercise. And inshallah, I'm going to show you the video that how we make a prayer as a therapy. Okay. Okay, this is what I'm talking about, revolution. My topic will be the revolution. So if you can see here, oh, okay. Okay, you can see here, the first model is actually a sheet of paper. You can imagine what your patient will do if you supply them a sheet of paper. You know, this is what we call cotton could-see exercise. This is world standard. It's very good exercise actually, but the weakness is actually they don't have in form of book, they don't have in form of poster or video. So it's going to be a lot of error. You know, especially for aging people, they are so, you know, it's not their time to read and to do something. So we are, as a clinical, need to be innovate. So Cotton could-see by Dr. Cottons and Dr. could-see by 1983, 84, which is 31 years ago. Okay, so when I'm doing the attachment in UK on 2006 and 7, Alhamdulillah, from that experience, I can learn the second method, which is that we call customized Cotton could-see exercise. But they are still in a sheet of paper. You can Google. You can just put customized Cotton could-see exercise. You can see and print what the kind of exercise. So next step, what I'm saying about revolution, Professor Marusa Paula from Imperial College London, they make a study on simulator base. It's kind of like you introduce a disco light room for your patient. This is a really good therapy. Not ask people to go disco, no. But I think I'm saying to you, the disco room is quite good therapy for those who are having visual vertigo. That means they cannot see the faster light, fast movement, and all those things. Then, it's coming our innovation. Actually, I love innovation. The reason why, when I back from UK, I'm only given one bag, one pillow, and one blanket. So I don't have anything. So start from that. Start from the weakness and the lackness. we already have our own innovation.